So this is Blue Cirrus's presentation, what big ROIs you have. So we like to mix fun topics with serious topics so that you not only remember them, but it might be a little bit entertaining as well. So I'm Michelle Hager. I'm the managing partner of Blue Cirrus Consulting, over 20 years in healthcare IT. In the last 8 years or so, I've been dedicated to the development of telehealth and telehealth strategies for all sorts of organizations across the country, including Intermountain Healthcare, Adventist Health, Prisma Health here in South Carolina, and the Virginia Rural Health Authority. I'm also active in HIMSS, which is the South Carolina chapter of HIMSS, and I'm the immediate past president of South Carolina chapter, as well as a chapter advocate, and I have been a vice chair of public policy as well. I'm on the advisory board for CTEL and on the industry council for the American Telemedicine Association. So let's talk a little bit about return on investment. Sometimes it can be a little bit like Red Riding Hood reaching the wolf and getting that sort of scare that's happened. How am I going to actually get a return on investment from my telehealth program? And often when we work with organizations, we let them know not to just focus on what it is that you can get paid for directly. I understand that you have to do that, and we will talk about both the revenue generation opportunities, but also where the soft dollars are as well, which end up to convert to real dollars, and we'll talk about that in a minute. For hard ROI, for those dollars that are real in your hand, you can obviously receive fee for service, particularly now during the PHE. We see quite a bit of reimbursement, as well as CMS showing us that they are going to continue to service some of the reimbursement that we saw during the waiver period of the PHE. That will continue, or at least they're proposing that some of that continue. And also some of the variations in the way that the cost models will work with CMS going forward. And we'll talk a little bit about that as well. So cost reductions, we also see that quite a bit in organizations, both large healthcare organizations as well as smaller, particularly in the large healthcare organizations, reducing cost of care being huge in terms of them being able to increase capacity, to be able to increase the ROI for a particular service. That's also true for small organizations as well. And then avoiding costs for those organizations that are subject to readmission penalties. Avoiding those costs that could be associated with a readmission, for example, is a very specific and real dollar that could be affecting your organization. On the right-hand side, the soft ROI, those quality improvements that you can see, those include that ROI dollar, and quality improvements can be dollars as well. In addition, labor capacities and efficiencies. It is over and over and over that we see labor capacity improvements as part of a telehealth program. So not only are you looking at how many visits am I doing, how can I improve the volume of the visits that I'm doing and encourage adoption from my patients as well as my providers, but where can I allow my providers who might not be completely on board, show them how this is going to improve their labor capacity and efficiency, so that they're able to see more patients in a day, they're able to manage those patients more easily, and also be able to return that investment for those visits. And of course, patient and provider satisfaction. I know right now we've seen a lot of folks that have installed telehealth very quickly. And what's happened in installing them very quickly is they haven't always made the best decisions in terms of technology, in terms of process, and in terms of workflow of how they implement that telehealth program. And that has caused particularly provider satisfaction to go down. And we've seen as a result, adoption rates go down from a provider perspective. So we know that across the country, we're seeing the rates going all over the place, and we'll talk a little bit about that, but we're seeing them consistently over the last 2 months as folks have looked at managing COVID exposure, that they have seen a reduction in telehealth visits and less and more face-to-face visits as they've been able to manage those visits and potential exposure. So it can feel a little bit like the wolf in the woods coming out to scare you, but we're going to talk about all of them, and that will make it a lot more easy for you to understand. We know that CMS has just put together their chart organization models and their chart models, and this is a snapshot of one piece of that, which I think very well demonstrates where CMS is coming from. And they are looking at 3 different scenarios. One where quality improves and cost is neutral. Another scenario where quality is neutral, but cost is reduced. And then the best case scenario where quality improves and cost is reduced. So we know that CMS is driving towards a value-based system. We know that they are driving towards reducing cost. And we know that now CMS has seen the volumes of telehealth visits and where that can be used to improve not only the ability to access care, but reduce the cost of care. So they're definitely looking at those 2 as the best case scenario. So we're going to look at both quality improvements and revenue opportunities, which include cost reduction and cost avoidance. In a value-based system, we know that they implemented this CMS value-based system with the goal of putting together the CMS Primary Care Initiative. And that goal is to shift from a fee-for-service program to a value-based reimbursement. So we can see that in the plans that they have moving forward, and that is the direct contracting, where we're looking at providers taking bigger control, taking more risk associated with the cost of the populations within their Medicare, in particular fee-for-service patient population, as well as the primary care first, where it's incentivizing those providers to reduce the cost of hospitalization, utilization, and also total cost of care. So we know with primary care first, for example, on the right, that this represents high need population where this will provide higher payments to practices that specialize in care for high need patients. So those that are on the rising risk or high risk, therefore high need patients. And these are coming directly from the CMS shared service program. So you can research, we always reference our slides, so you can research that for yourself. This is data as of January 1st. And when we look at the direct contracting opportunities, that's both geographic. So those that are responsible for a total cost of care for a population, obviously with low risk, high risk, and rising risk. Those that have global, where the organization is going to bear a full financial risk for those patients and that population, and those where we have a shared financial risk with CMS. What's interesting is that we have over 517 shared savings programs, or ACOs, as of January 1st of this year, and 17,000 participants, over 17,000 participants in ACOs. So we're moving this forward. This is continuing to be the trend, and we know that CMS is moving this even further forward. Reimbursement challenges still exist today in the fee-for-service world. And it can seem, as you can see, grandma is really scared. She's got the wolf there now, ready to pounce and ready to take grandma and swallow her whole and assume her identity. And it can seem a little bit like that, particularly when you're in a state like South Carolina, where we don't have a parity law. We don't have a proposed parity law. So we need to start to think about and move things forward related to parity law in our state. We know that we've had good cooperation, at least up to this point, with some of the commercial payers, but reimbursement on fee-for-service is still a challenge. And the reality is that we know through COVID and through the public health emergency that telehealth has made a difference, not only with patients where they are not able to access care, but it has improved patient outcomes. And we have seen in our own state and across the country, and CMS has certainly seen this, that we haven't had the massive influx of usage of telehealth, which was always the fear related to a fee-for-service program. So not having parity now that we've seen what the numbers look like, is not what we want to see. We want to see all 50 states have a parity law, including South Carolina. During COVID, we've seen the telehealth response be incredible. So telehealth is known to be already high investment dollars in this space. We know recently in the news, we've seen many of our telehealth vendors be collapsing in terms of their market share. They're increasing their market share and collapsing companies together into one company. And we're also seeing them do IPOs, have increased investor dollars. And we also see, as a result, modern healthcare is showing that telehealth could grow to be almost $250 billion annually as a result of the pandemic. So no one, including Seema Verna, is saying telehealth, this was a flash in the pan. We saw it work in COVID. We saw it work during the public health emergency, but we're going to be jettisoning that after this program, after this public health emergency. That is not the case at all. We know that we saw a 50% increase across the board in primary care visits via telehealth. 46% of those patients are using telehealth now in place of in-person visits. And then, of course, providers are now seeing over 50 to 175 times the amount of patients that they used to see via telehealth. And of course, you've seen these numbers, you've probably read these numbers yourself, but they're exponential in terms of the increase in the amount of visits that we've seen. So many of those billing codes have been expanded now because of this during the public health emergency. And you can see some of the codes or some of the services that have been expanded. They are listed in the center. But even the AMA has said that telehealth will result, AMA is saying that telehealth could result in 20% fewer visits when we finish the public health emergency and we look at that data post PHE. 35% of home health could be virtualized. And we all know that from our day-to-day lives, and home health is a great use for telehealth. We just need to have the reimbursement in the right place. 24% of the outpatient visits could be delivered virtually. I think that number even could be a little bit higher in terms of the outpatient visits. And 2% of outpatient visits could be shifted to the home setting. Another reason to make home as an allowable site for telehealth reimbursement. I think those numbers in 24% and 2% could be a little bit higher, but even the AMA is saying those are possible. And of course, they've always stayed fairly conservative in terms of the usage of telehealth in replacing a face-to-face visit. What I want to make sure that you do is don't recreate the wheel. So when you're doing a telehealth program and you're looking at how do I get my ROI, and someone hands you the wheel already created and it's already nice and circular and perfect, don't say, no, thanks, I'm too busy dealing with my day-to-day job. I'd like to continue with my square wheels. So when we think about a soft ROI, for example, look for metrics that you're already tracking. For example, some of the metrics that you may be using for inpatient quality reporting, pay for performance, any of the outpatient quality reporting programs, any of this PQRS, Medicare Access or CHIP, MACRA, any of the MACRA performance metrics that you may be identified with, or even those related to ARC or HEDIS. And again, all those are referenced. What's important here is not that you look at what the organization is already tracking so that you can just be lumped into the rest of those programs. That's not what we're talking about. We're saying measure the same thing that you're already measuring on the inpatient side. So if that's patient satisfaction, or if that's falls, or if that's blood pressure tracking or hypertensive patients, et cetera, or readmissions, look at it in relation to telehealth. So we know that Press Ganey, for example, is already putting together some questions for telehealth. Those already exist today that you can include in your surveys in terms of satisfaction and how satisfactory were your telehealth visits. But when you're looking at some of these others that we mentioned, measure those for your telehealth visits, have a way in your EMR or your reporting structures, or if your telehealth vendor isn't already giving you that information, ask them to provide that for you. Many times they have reporting capability that they haven't done as part of the out of the box capabilities. So ask them to provide some additional reporting for you so that you can start to capture that information for telehealth visits only and compare how are you doing from a face-to-face visit compared to a telehealth visit. And you should be targeting for as good or better than what you see in your face-to-face visits. So as good visits allows you to see we're doing just as well, everything is working as planned, we're getting just the same amount of value, and we're getting the same amount of patient outcome. If you see something dipping below, then you can start to take a look at that measure and determine, should I be identifying something a little bit different here? Should I be adjusting this program in some way such that I can improve the numbers that I have on this program, whether that's adoption, whether that's catching the patients that you intend to catch, or whether that's just improving the outcomes of those patients. Here are some other virtual visit performance metrics that you may want to consider identifying and using to compare to in-person visits. So HEDIS utilization, as we've talked about, both mental health utilization, your readmission numbers, your hospital utilization, controlling high blood pressure. These are all numbers that you are likely measuring today in both your offices, rural health clinics, FQHCs, as well as major health systems. And we've got them all referenced down there below. These slides are available through the PCC website as well. So you can look at them, either take a picture of them today, or you can look at them at another time through the recording. And you can see the measure title goes for influenza screening, vaccines. You can look at all of these types of things related to telehealth as well, controlling high blood pressure. So are you able to determine whether or not someone has received vaccine, or even encouraging them to get vaccines through your telehealth visit? Anything like that, you can help to move the needle on your existing measures. Some additional performance metrics that we see that are coming out of ARC, which is another great organization to look at the quality indicators for your clinical service that you're providing. So again, these are soft dollar ROI. However, many of these have real dollars associated with them. So if we know that patients are readmitting because of hypertension, or we're seeing patients readmit because of their CHF status or COPD status, then we can directly relate those to dollars that are saved for the organization. So Little Red Riding Hood comes in now that the wolf has consumed grandma. Little Red Riding Hood is looking and saying, I'm not really sure. It seems like you're not the same as my grandmother normally, although you'd think she'd be able to catch on to that pretty well. She must need to have some glasses. However, this can seem a little bit like a fee-for-service scenario. You're like, I'm not really sure. Is that what it's supposed to be, or is this what it's supposed to be? So when you look at hard ROI reimbursement, you have to look at it in terms of the fee-for-service payment itself, and we'll talk about some of the codes that my friend Carol Yarbrough has done for me in this slide presentation. You have to look at your bundled payment structures. You're not going to get any more payment for those services, so you might as well try to be as efficient as possible. So finding out where you have the big teeth that you have, the big eyes that you might have, and the big ears that you might have, both in looking at clinical contracted services to other organizations, if you have some additional capacity that you've gained through the process. Look at reimbursable care specifically for fee-for-service, and also could you get into a risk share scenario because you feel like that works out really well for your organization, you're able to manage that risk. And looking at downstream revenue and grant funding to start up. We often talk about in telehealth grant funding being a little bit of a double-edged sword, but in this age of COVID, we've seen a tremendous amount of grant funding that will help organizations be able to purchase particularly equipment. And then we see that also from not only FCC, but also in USDA, putting those two pieces together and allowing those expanded opportunities for grant funding to be able to get technology. So normally that wouldn't be a big part of the opportunity here, but for many where they haven't done telehealth previously, that's to start up. And we know that USDA is still accepting applications, I think, through the middle of October for their new opened up REST grant. We've seen telebehavioral health, for example, that is one of the biggest reimbursable services. And some of you may have seen us talk about this in previous presentations, but I'll talk about two different scenarios. These are real clients where we did pro formas related to their 5-year potential ROI for telebehavioral health. This happened to be in a children's hospital environment, and they had a tremendous amount of behavioral health need. And we saw over the 5 years, $6 million with the quality performance metrics as well, with the soft ROI added, which is the dotted line, and hard ROI is the hard line. So when you think to yourself, it's not possible to get there in an ROI, it is, particularly now where we see so much payment, fee-for-service payment related to telehealth. And then as we see value-based programs continuing, we know based on the experiments that we see CMS doing that they're definitely experimenting and pushing towards utilizing telehealth to bridge that gap, both in physician shortages as well as in protection through COVID, and of course, in assisting in preventing rising risk for your patient populations. Here's another patient where we had this happen to be another children's hospital. Although our original ROI was not that high in terms of dollars, the soft ROI was very high. So for teleneurology, for this particular client, that was an opportunity for them to provide additional teleneurology services across their organization and to other facilities inside of their organization. And that represented a high performance metrics or high quality metrics improvement that had real dollars associated with it, based on the amount of travel that some folks had been doing, based on the amount of service that they had been providing, purchasing from other organizations, which obviously has a high cost associated with it. So lots of opportunities to bring an ROI to the program. We haven't seen any programs so far that are below the $0 line, so are losing money, for example, and sometimes initially they might, but they always end up being able to make some money, whether those are high dollars and real dollars or high dollars and soft dollars over the course of 5 years. So now that you know you've got what big ears you've got, what big teeth you've got, what big eyes you have a full wolf. You know now that there is a wolf there. It's not a wolf in sheep's clothing, it's a wolf in grandma's clothing. So how do we deal with this from an ROI perspective and a reimbursement perspective? So my friend Carol Yarborough, who's done another presentation and will be part of the question and answer session for this presentation, provided this information for me to share, and will also be on her presentation as well. But during the PHE and post-PHE for both inpatient and outpatient, we know that during the PHE, we have geographic site limitations waived, which is great. But we know that once that waiver is gone, we're going to see potentially the originating site revert back. We know that in some cases, providers located within 250 feet of the main hospital is not telehealth, because they're still saying, well, you should be able to get in there and do the work inside the hospital. So if you're located within that 250 feet range, you might want to look at why you might be getting denials, maybe because of your address that you have and how close that is to a hospital or to another main hospital location. But during the PHE, you can bill normally, even when video or telephone are due to, those are specific to time on the floor. So anything that you would have done normally and your time that you would have spent typically on the floor, it's the same kind of billing that you see with video and telephone during the PHE. These are a couple of codes for telehealth on the admission side, and if CMS, of course, they include the modifier 95 and place of service 21, and commercial insurances. We're watching those. We know that those are moving. In some states, they're shifting. For example, Arkansas, I know Texas has made some changes in which they have started to restrict both provider types as well as types of service that will be allowable as part of a telehealth parity. However, there are other states like New Hampshire that have opened them up, and Vermont that have opened them up even more. So we have a mixture happening across the country now that we have a PHE, we're going to see those change by state, and hopefully we'll start to see some leveling off. We'll see what happens post PHE on the inpatient side. Will we see modifiers? Will those revert? Probably so. We probably will be back to doing those modifiers as well. And then on the outpatient side, during the PHE, we know that the geographic site limitation has been waived, which is great because we're allowed right now to do home. We have addition of codes to maintain health equity and preventing this spread of COVID. So as we know, many codes were added, many codes were utilized, as well as telephone codes, those things that were audio only that allowed for a lot of expansion of telehealth. And this allowed for even more reimbursement during the public health emergency. And you all probably have experienced this or know someone's experienced this. We had many clients that we spoke to over the course of the public health emergency, particularly in March and April, where the clinic was closed down or the critical access hospital was almost closed. They were doing 1%, 2% of what they were doing before. Once we worked with them and implementing telehealth, getting their this was literally a couple of hours, and talking to them, they were able to get to almost 95% of their previous visits. So that saved those organizations from closing. And I know that's the same story for many organizations across the country, including South Carolina. We know that during the public health emergency for outpatient, we have the modifier 95, and then of course the place of service 11 for physician-based, 19, 22, depending on where you are, and then facility charges. With either one of those, you can go for. And I know Carol will talk a little bit about that a little bit more. And then post CPTs, post PHE, will we see CPTs revert? I personally don't see a lot of them will, although we know from CMS's documentation that they are looking to remove some of them. In particular, on the inpatient side, we're seeing discharge day and critical care information, which critical care is arguable. We're able to do some rounding, for example, on critical care patients via telehealth. And we know that the HRSA eligible geographic area requirement will reverse unless there has been passed legislation expanding those locations. So that's a primary concern right now, in addition to broadband access. So the home will it continue to be a valid originating site? It will be for ESRD patients and then substance abuse patients. But right now, post 8 PHE, we will see those things revert. We know that access to care has been a huge concern, or in a huge way for telehealth to reach patients, not only just during COVID, but also even pre-COVID. So the average time for a typical in-person visit, according to our referenced information from various organizations that you can see down there at the bottom, we see 20 minutes for a standard time for a telehealth visit. Typically with telehealth, for an in-person visit, typically with telehealth, we're able to save a tremendous amount of time because a virtual visit will be 8 to 10 minutes. In some cases, even 7 to 10 minutes. And some can even, that's an average time. So it just depends. Some organizations have been allocating 30 minutes for a virtual visit just to be able to make sure the technology works, something along those lines. Make sure if you're doing that today that you really look hard at that. You shouldn't have to do that. Most virtual visits are much smaller, much less time than that, mostly down to 8 and 10 minutes, as you can see here. And the average cost is only $79 versus an inpatient visit, which can be up to 120 minutes and then $146 cost. So much different in terms of virtual visit versus in-person visit. And then on the rural community side, we know that 46 million Americans are living in some kind of rural area where access to care is a huge issue. 15% of those of the total US population lives in some kind of rural area designation, and 18% of that rural population is over 65, where we know the cost of care is the highest. And so reducing the cost of care for that age group is even higher, is even more important. And then at 1.7%, the rural population is 85 plus. So again, even more important that we look at rural as an opportunity for us to continue to provide telehealth care and continue to get reimbursement for that care. So building capacity in your organization, finding a way to use telehealth as a bridge for clinical needs that you don't currently have. So for example, you can see in our picture here that you can't just do that alone. In this case, Little Red Riding Hood couldn't defeat the wolf on her own. She had to get the woodsman to shake the grandma out of, and herself out of the wolf after he ate them. And then after they all got together, they both all ran towards the wolf and worked together to be able to defeat the wolf and have, a happy ending. And the same is true for telehealth, working together to find a way to bridge those needs. So for example, you might think today, well, I don't want to use an outside provider because that's not going to be working for me and my organization. The culture of my organization doesn't allow me to do that. The physicians aren't going to be necessarily happy with using outside clinicians, but perhaps you don't have that clinical expertise today, or you don't have enough of that to be able to bring in a full practice. We'll utilize an outside organization to build that practice, to build the need, to fill the hole where you have it, and then you can abandon those companies and you can do that on your own, or you can continue with them if that's what works for you at that time. But it depends on the culture of the organization. And telehealth, as we know, builds capacity in your existing schedule. We talked about how average visits are anywhere between 7 to 10 minutes. You can always use telehealth with a bundle payment. This makes complete sense. In many states, you're able to use a telehealth with your advanced practice professionals, encouraging you greatly to do that as much as possible. Save your physician expertise for those patients that you need to see for sure. And you need to do some patient selection criteria inside of your own organization to determine which ones make sense for an APP to do versus a physician to do. But using them, particularly with bundle payments, makes complete sense. And then now we know in the age of COVID, we're looking at reducing overhead costs now with real estate, which also reduces your overall cost because you'll now have a smaller footprint. So not only are people now working from home more in standard businesses outside of healthcare, but now we're seeing even healthcare workers working from home as well, taking into consideration security and privacy, which can remove the need for as many footprints, locations, real estate spaces that you have today. You may be able to reduce that and reduce your overall cost of care. And access specialty care when you need it via telehealth. Learn how to do those services, as I said, and then do it and then operate independently. Abandon someone that may be helping you for that short period of time to bridge that gap. Utilize as much help as you need to, take advantage of that, learn from someone else, and then run and take it on your own. It's been a pleasure to talk with you here at PCC. I always enjoy this conference. It's a great conference for lots of different information, lots of folks here from varied backgrounds. And if there's anything that I can answer for you, either on this webinar or afterwards, please feel free to contact me. I would encourage you to follow us on Twitter, LinkedIn, and Facebook. We also, on our website, bluesirrus.com, share a lot of free information. We do webinars every month. Just about every month. We do a podcast as well, and this is all in our knowledge tsunami. It's all free information. So please take advantage of that as you need to be able to grow your programs and get the biggest ROI that you can from your program.